See, historically, the old way to treat stuttering was that all treatment for preschool and young school-age children who stutter was indirect. That is, in indirect therapy, no specific instructions were provided to the child about how to change his speech, or even any discussion about the fact that he was in therapy for fluency work. This is all based on the old diagnosogenic theory that I talked about in part 1 of this course, which focused on the idea that stuttering didn't arise due to anything that the child did, but rather through an environmental misinterpretation that the child's normal disfluencies were in some way unacceptable. That in turn caused the child to feel self-conscious, and that's what led to further disruption in his speech. As I pointed out in part 1, today we know the diagnosogenic theory is not true, and we can let go of all of those old fears that we had about talking about stuttering for fear that it would make it worse. Today we know that's old news. Times have changed. We can talk about stuttering, and in fact, doing so will help. More recently then, some newer ways to talk about stuttering, some newer ways to treat stuttering, have moved toward more direct intervention. This can be done in several ways. For example, direct discussion of fluency-enhancing speech strategies, just like we might do with an older child, but now scaled down to the needs and the abilities of a preschooler. Yeah? And combining that direct work on fluency with some standard work that we're already familiar with on modifying the environment, reducing demands on the child, reducing environmental, contributing, not causal factors. In other words, much of what we've done in indirect therapy over the years was okay, it just didn't necessarily go far enough. One way of doing direct therapy is to combine that indirect work with more direct work on the child's speech fluency and, importantly, on the child's communication attitudes. Again, like we might do for an older child.